Good morning and a very warm welcome to Day 2 of EMCDDA 2023. Welcome to the many of you who are here with us in the room and the thousands of you who are watching us online. Wherever you're joining us from, you are very welcome. In this opening plenary of Day 2, as I mentioned earlier, we are discussing wastewater surveillance and asking the question, is it a magic bullet or just one piece of the puzzle? And in order to chair this session, I am delighted to hand over to Jacobo Mendioroz, who is Sub-Director General Surveillance and Response to Public Health Emergency in the Public Health Agency of Catalonia, and Henriette de Valk, who is Head of the Foodborne, Vector-borne and Zoonotic Infections Unit at Santé, Publique, France. Henriette, Jacobo, please, over to you.
Good morning. It's a pleasure for me to welcome you all to this session, Wastewater Surveillance. Is it a magic bullet or just one piece of the puzzle? And just to start, I think most of you are familiar with the concept, with the approach of wastewater surveillance. You know, it involves monitoring wastewater for the presence of biological markers like viruses, parasites, or bacteria, but it can also look at the chemical contaminations like drugs or pesticides or environmental toxins. And it's not new, it's not a new concept, or a new approach. We have been using this in infectious disease surveillance for many years, and the most well-known, I think, is for polio virus within the framework of the eradication program for polio. But this whole approach regained a lot of attention suddenly during the COVID-19 pandemic, when, because of its widespread implementation in many communities throughout the world. And it raised a lot of expectations also and hopes for its use. And since there are also experiments and works going on to include a broader range of markers, not just SARS-CoV-2 and its variants, but also looking at endemic or newly emerging threats. Like, for instance, Mpox, it was used quite often, and countries are looking at influenza. And so we thought at this point in time, you know, many of you, we assume, many of you have been confronted with the data, have perhaps been working with the data, have been thinking about setting it up or have set it up. And we are in a point of time where we thought it was a good moment to sit down and reflect on this, look at the limitations of such surveillance, look at the potential benefits, and look also at lessons learned, not just in infectious diseases, but also in other fields. We have a speaker who comes from a different domain. And so together see what can wastewater surveillance contribute for our infectious disease surveillance. And for this, we have three very interesting speakers from different domains, and I have the pleasure to ask Jacobo to present the speakers to us.
Thank you, Jet. So I would like to invite our speakers to the stage. I think we have three very important representatives of what we're talking here. In the first place, we have Marta Vargha, that is currently, please come here. She's a chief counselor of the National Center for Public Health and Pharmacy in Hungary, and responsible for water hygiene. She's the head of the WHO Collaborating Center for Environmental Risk Management and the current chair of the WHO Euro-UNIS Protocol Water and Health. And she has made a fantastic work, you know, when we drink water to get it potable. He has made some interesting research on all types of contaminants that we usually don't think about it, that as arsenic, lead, yeah, a lot of even radioactive substances. So she has a lot of experience of detecting contaminants in the water, regulation of the water, and I think it will be a great speaker for this first session. Okay, please.
We introduced the three.
The next one will be Paul Griffiths. Please come on stage. So Paul Griffiths is the current scientific director of the European Monitoring Center for Drugs and Drug Addiction. He has a huge experience of the field. He has studying for more than 30 years all matters related to drug and drug addiction. No need to say that it's a public health matter, the situation that we have now with drug consumption, new drugs, the fentanyl crisis. But also I think it's very relevant that from the European Monitoring Center for Drugs and Addiction has put in place a lot of different tools because humans don't want to be tested drugs, so we have to find different ways to see consumption, including the water ban. And I think this, even if we're not very used, it will be very interesting to ask his point of view on how we can surveillance of other things. Last but not least, we have Professor Marion Koopmans, please come on stage. Professor Koopmans is the director of the Department of Bioscience at Erasmus Medical Center in Netherlands. She also is the Collaborative Center for Emerging Infectious Disease, Scientific Director for Emerging Infectious Disease of the Netherlands Center of One Health, and Scientific Director of Pandemics and Disaster Preparedness Center in Rotterdam. It's also, I think she has maybe an anticipated vision because she has the perspective of One Health that we all talk about now. He has centered her work about the transmission between the animals and the humans, the way that how diseases go from one another. Huge work, very, very interesting. I think it's a pleasure to have you here with us now. So now, for the start, I think we're going to explore a little bit if you use the waterborne surveillance and, well, maybe give a general perspective of the audience about what you think of it.
Yes.
So, Jet, please.
Yeah. Yes, so I started saying I think we assumed that most of you or many of you have some experience with wastewater surveillance or have come across data or whatever, but we wanted actually to check this and have a snapshot with 2 simple questions about your experience with this and your ideas. So we prepared 2 questions, so if you can get your Slidos ready, and then let's look at the first question, which we will have on slido.com. We asked you if the institution you work for, or you yourself, does your institution you work for use wastewater surveillance and data? And then you can choose. It does not use wastewater surveillance data. It is planning to set up and use wastewater surveillance data. It uses wastewater surveillance data already, but just for information, or it used or uses wastewater surveillance for decision making. It could be, for instance, it used it during the pandemic, but no longer, or it's still using or recently used it. So if you can just click the reply that suits you best. Okay, well, perhaps let's look at the results, what we get for this question. Okay, 41 has used or uses wastewater surveillance for decision making. That's a big shot. And then 29% uses wastewater surveillance for information only. 20% does not use wastewater surveillance data. And 9% is planning to set it up. That's pretty low, but that's because they do it already. So I think we were pretty right that many of you have come across this approach and are dealing with it. Okay, thank you very much. And then let's look at the second question. What do you personally think about wastewater surveillance and data? Now, there's no perfect answer, so just pick the answer that suits you best. Other surveillance tools are sufficient for my data needs. Wastewater surveillance and data should be used alongside other surveillance tools, and wastewater surveillance and data are important and should be used as a key surveillance tool. Okay, we are having a common opinion here. 83% wastewater surveillance and data should be used alongside other surveillance tools. I think it reflects a little bit also our title of the session. And then we have, well, 13% that thinks there should be a key surveillance tool, and other surveillance tools are sufficient for my data needs, 4% only. I think this is a very interesting perspective, and I'm sure the audience will be very interested in your different presentations and experiences. You can produce Marta.
Yeah, these are quite impressive results.
Yeah.
So many people use wastewater surveillance alongside to decision making is the final part of the process. So, well, we will start with the presentation of Marta Vargha that will talk about, well, her experience, as I said before, especially about the UE Joint Action Project on wastewater survey. So, whenever you're ready.
Thank you so much. Thanks for the introduction, Jacobo. Indeed, I'm coming from the direction of water hygiene and environmental health to EMCDDA, so it's my first meeting and I'm really happy to be here. And I'm really happy to see that so many of you already are acquainted with the concept of wastewater-based surveillance. But just to introduce you to the very basics, practically anything that's shed into feces, to urine, or washed from the body will end up eventually in wastewater. So when we take a wastewater sample, we can use it as a fingerprint of the health status of the population connected to that wastewater treatment plant, and can use it for many purposes, as already just highlighted. So it's not only for pathogen circulation or detection of variants, but also things like AMR or illicit substances, even for consumption of alcohol or tobacco. And there are markers of health status and non-communicable diseases that can also be seen in the wastewater. The first 50 years of wastewater-based epidemiology were about polio. And then from the advance of the 21st century, there was an increase in interest towards illicit substances and metabolites in the wastewater. And there was a sudden surge from 2020 towards SARS-CoV-2. So the next question is, what comes next? What will be the next era of wastewater-based surveillance? And apparently you are also interested in that. You already answered about complementary surveillance systems, but just to reiterate, these surveillance systems have different targets and different scopes. So wastewater-based surveillance will pick up everyone who's infected, whether they are symptomatic or asymptomatic, while a clinical surveillance will complement that with detecting those who have symptoms, and hospital surveillance will add to this prospect those who are severely ill and need hospital care. While the target of the surveillance system is slightly different, the outcomes are very nicely complement each other. Just to flag a few of our own data, in the early days of the COVID pandemic, back before Omicron, we could predict the number of cases about 1 week ahead based on the wastewater surveillance data, and the number of hospitalization by 2 weeks ahead. And this is very similar to that what other people are finding or were finding at that time. With the advent of Omicron and its subvariants, this window has been closing a bit. We are seeing shorter lag times between wastewater data and clinical data, but now we have a much limited access to clinical testing, or much less data from clinical testing, as people are not as eager to get tested as they were in 2020 or 2021. So now, from another perspective, it's becoming, again, a very important source of data. The other example is the influenza and symptomatic cases, and there also you see a very nice correlation. If you look at variants, again, complementary information. Wastewater will tell you what's circulating in the population. and clinical data will tell you what's making people ill. Wastewater surveillance is not a single method. It's a tool that can be used for many purposes. And depending on what's the purpose, the aims and the sampling points and sampling frequencies might be very, very different. The concept we know best and use most is tracking disease circulation. This is what most people have been doing during the COVID pandemic, just to show, outbreak trends, whether they are increasing or decreasing. It's also, as I said, has a potential for variant tracking, but while the list I've used here for use cases is from the WHO guidelines on environmental surveillance for SARS-CoV-2, it actually can be generalized to other health features as well. So in those settings, for instance, which we assume to be free from a certain disease, it can give a first indication of the emergence of a disease, as it was in the case for Mpox. It can also direct other interventions. So, for instance, if we see the emergence of a disease through wastewater surveillance, we can target clinical surveillance or a more intense clinical surveillance to that area, or use it as an indicator for a need for vaccination. It also then can help to monitor the efficiency of these interventions. And also helps the tool, for instance, we have been using this very much, the information coming out from wastewater surveillance to raise awareness in the public that even though we are now we are not focusing so much, the COVID is still with us. It's been a hot topic in the recent years, and there are many initiatives which picked up wastewater surveillance. In the European Union, there's a recommendation for all countries to set up a surveillance, and with the recast of the Urban Wastewater Directive, we expect it to become an obligation rather than a recommendation. WHO has also published guidelines on how to do this and why to do this. And also in the new EMR roadmap, there's an explicit reference for the usefulness of wastewater-based epidemiology. Just last week, there was the first international conference on wastewater surveillance and the roadmap towards a global surveillance in Frankfurt. And there is a website under the telltale name of COVID Poops, which collects initiatives. And the last time I looked at it, there were already 72 countries employing wastewater-based epidemiology. There is a really large and very important undertaking in the European Union towards further advancement of wastewater-based epidemiology, and that's a European joint action, which is being led by Denmark and Greece. Actually, one of our precious leaders is in the room, Steen is here. All member states are project partners to this initiative, and also Ukraine. The main aim of this project is to streamline existing practices toward a tool that can really help public health decision making. So we will look at existing practices, we will look at targets where wastewater-based epidemiology could be most helpful, and really looking into how this tool could be integrated into other surveillance and the process of public health decision-making. We just got the ball rolling, so we started November 1st, and we're very much looking forward to how this project will evolve and the outcomes of this project. Just to wrap up with a few key benefits and challenges of wastewater-based surveillance. It's fairly cost-effective in comparison to other surveillance methods. It's non-intrusive, and it can provide a representative sample from a large share of the population. It's not sensitive to access or willingness to get clinical testing, and because of that, it's also a tool to help equity. Since wastewater-based epidemiology can reach those isolated populations or those marginalized groups who are less likely to seek medical care or to go for testing, we can still get information about those groups using wastewater surveillance. It has a fairly fast turnover rate. Yesterday, in a talk, I've heard about 2-3 weeks of turnover rates for outbreak detection. Well, wastewater-based epidemiology can give you that in 24 hours, and it nicely complements other surveillance systems. So far, though, wastewater-based epidemiology has been largely research-driven. So people have been looking at what we can do with wastewater-based epidemiology. Now we need to see what it needs to do, what is the actual public health question it should answer, and therefore it should be adapted to the needs of the local communities. Advanced use, as you will hear from Marion, need extensive bioinformatic potential, which needs to be developed if a country is wishing to use it. And there are definitely sources of variation due to shedding or dilution with precipitation water in the sewage and others. It cannot be directly translated. There have been attempts, and some really good attempts, to translate the titers measured into disease rates, but none have been fully successful. And of course, sensitivity is an issue that we will need to address. So this is just a really quick overview of what wastewater-based epidemiology can do for you. Other speakers will detail it more. The motto has been used in the communities: not everyone gets tested, but everyone uses the toilet. So this is the idea we start with, and I would like to acknowledge here the people who participate in this work in Hungary, and also the EU Wish community, which is a very dedicated and eager community, which is great to work with. And of course, I thank you for your attention.
We have good questions.
Thank you very much. We have some questions from the audience that I will translate to you. I think it's very clear for everyone that the surveillance system is useful when we talk about raising alerts, so especially we were making surveillance of eradicated diseases like polio and ulcer. But I think, what would you think are really the benefits, and what's the difference with the traditional system that we have in place in hospitals? I know you just make a resume, but if you want to take some special points that you think that really add value over the traditional surveillance system on the wastewater, what would you choose?
I think representativity is definitely one benefit. I really like the concept of equity here because it's we know that in the population there are many groups exist who will be less likely to seek care or have less access to testing. And I really like the flexibility of it's very quickly can be adopted once the system is set up. It's very easy to adapt it to other purposes. So because really the sample collection and the logistics behind is the most difficult part. Once the samples are in the lab, you can get out as many information from it as possible.
That's very important. We usually, as clinicians, forget that we have marginalized populations that don't get access to the hospital, and especially when we're talking about infectious diseases, they can be really, I don't know, clusters or outbreaks coming on difficult, accessible populations. So the other one is a little bit tricky because we like to make epidemiology on different subsets of populations. So you cannot, or maybe you can, I would like to know your point of view, relate the diseases on age population, on different subtypes of population. It's a question about maybe we're losing the impact in children that are younger than 2 years, on specific populations that we want to know. Is a possibility that wastewater can help us also to characterize the diseases in different populations, more than spatial and temporal time?
It would probably require a special setting. So, for instance, targeting elderly care homes would give more information about an aged population, or targeting schools will give information about the problem like disease circulation, but even that, but other information on the health status of children. So I think it's possible, but the closer we get, the more ethical issues we will have. So the smaller population we are testing, the more question of privacy will come up, and those ethical considerations.
Okay. One more, and then I ask you a personal question. I think it's very interesting because we're talking about developed countries, but there are other countries that maybe not have the system of sewage and collecting waters, especially in the sub-Saharan Africa. Is there any bilateral frameworks or initiative that will maybe can help them to develop the capacities we're talking about here?
Yes, developing countries have a difficulty because there are very often they are not relying on sewer system. So if it's a non-sewer system, you also already have a problem where to sample. But surface waters or open ditches receiving sewage have been successfully used for detection of different diseases. So there is actually a potential there, and the low cost of a relatively low cost of wastewater surveillance is also an advantage when using in these settings. Under the EU WISH project, we do hope to reach out to other communities in capacity building, so not just within the European Union, but also outside of the region. And we hope that the work coming out of that project can actually assist other countries in setting up a wastewater surveillance. I know several initiatives include this as well, including the roadmap toward the global surveillance, as it was discussed last week in Frankfurt.
Okay. So last one, and I think it's a debate that we always have. We have limited resources. We have to place our funds in, systems that add value. So I'm a general manager, and I'm asking you, why should I put my resources in a surveillance system like that instead of maybe enhance the traditional ones that we have in hospitals and testing in humans? What's the feedback for the money I will invest?
I think if you want to have data for a large share of the population, which is really representative and it's not sensitive to inclination to get testing, then wastewater-based surveillance is definitely has an added value there. And also, maybe if you look at specific situations, wastewater-based surveillance can give you answers, and those answers will be different in different settings. So if you have, so to speak, a peacetime surveillance system targeting things like AMR, for instance, so things that will not change very rapidly, and you don't really need to have a prompt response on how they are evolving, that will be a completely different wastewater surveillance system that when you're in the middle of a pandemic and you will need to trace the outbreak and the disease circulation, it's fairly rapid turnover. And that's yet another system when you have, for instance, a disaster situation and you really need to know very quickly and very simply whether there is cholera emerging or typhoid emerging after an earthquake or in another disaster situation. So I would say it's not a question of why, it's a question of when and how. And we really should keep in mind that it's not a tool, it's a toolbox. And it can be used for many ends and can be a great support to public health decision-making.
So I think we all agree with the audience that is a complementary system, but that we also have to look for and integrate in our traditional surveillance system. So thank you very much.
Thank you very much.
Okay, then it's time for our next speaker, Paul Griffiths, with an extensive experience, because he's, as he calls himself, an early adopter, but in a completely different field. But I think we have many lessons to learn from him and advice to take. Thank you, Paul.
Good morning, everyone. And really now for something slightly different. I want to talk to you about how we've used wastewater analysis in the illicit drugs monitoring area. I'm going to give you a little bit of history about that, but I'm really going to focus on the barriers to adoption and how they were overcome, because they are more generally transferable, and I've got no conflict of interests. So just give you a little bit about the background in the drugs area. Really started with an early study from 2001 in the US that demonstrated that pharmaceutical drugs could be detected in the aquatic environment at much higher levels than expected. And that got people thinking a little bit. And some Italian researchers thought, is that more generally transferable to the illicit drugs area? And there was, I think, a groundbreaking study in 2005 in Italy, where they looked at drug residues in the river Po in Italy, looking at cocaine residues in that river. And then that prompted, after that, you start seeing a number of demonstration studies replicating that work across the different European countries and US, but all done using very, very different methodological approaches. But for us, for my agency, it all started with this guy here, old George, who's responsible for many things in the world, not all of them good. And what happened, I think towards the end of 2006, maybe it was early 2007, I got called up one afternoon by someone I knew from ONDCP, that's the policy office from Drugs Policy Office in the White House in America, saying, are you guys doing anything with sewage epidemiology? It was, I think, with sewage analysis in Europe, because we're getting a lot of pressure from the President's office. He's really worried about spying on Americans through their toilets. And I thought, God, that's really weird. No, we're not doing anything about that. I hadn't heard of it. I thought it all sounded a bit bizarre and amusing. But at that time, I had, as luck would have it, a staff member came in later that day and was looking for a new project area to work on. And I couldn't think of anything else. I said, why don't you have a look at this sewage epidemiology? It wasn't even called that in those days. And from that work, what happened was in 2008, we had our first Testing the Waters conference, technical meeting, and we produced our first technical manual on this topic. And during that meeting, I went along to that meeting feeling it was all a little bit strange and bizarre, not really taking it very seriously. And then at some point during that meeting, I suddenly had a eureka moment thinking this is a potential game changer for the drugs field, ability to produce real-time quantification of drugs consumption at the population level, is something we've really had to struggle with in the drugs field before. And I got very enthusiastic, the team got very enthusiastic about this approach, and then we immediately realized that we needed to overcome considerable technical, political resistance and some skepticism about this approach. And I think a lot of that was due to a lack of understanding of the method, a little bit of fear of the new, particularly from survey researchers. I think lots of survey researchers at the time thought we were going to put them out of business. And also in the drugs field, there's a sort of feeling that sometimes testing is just simply wrong as a point of principle. There was a lot of exaggeration of the technical problems and the limitations. I think there was a concern that the method was being oversold as a magic bullet, and also, to be honest, a little bit of overselling in some quarters. And there was also ethical concerns, and particularly ethical concerns was a new area. We didn't really understand what were the ethical issues, but also there was also the idea that this was also going to be used for operational purposes in the drugs area. So we had some countries looking at doing testing in schools to look at drug use there. One country wanted to look at health and safety issues around oil rigs, for example. And then it all got a little bit worse. The UNODC managed to get hold of a very preliminary and not very well conducted study from a very small Spanish town. It ended up in the World Drug Report, suggesting that this very little town in the north of Spain had the second highest cocaine consumption rates in the world. It much bemused the small, the rather aging population of this area, and it got very much annoyed Spanish policymakers. We got an awful lot of flack about this. And there was also some strange stuff going on around some media companies started testing politicians, which they didn't like. So we had to overcome a number of barriers, and I think there was a number of ways we did that. I think first, really important was establishing a community of practice, the SCORE collaboration, and they went on now, they've become a global network, and they really started doing standard setting, validation and accreditation, so really getting the nuts and bolts of the method sound. We were lucky enough to lobby for and get some European funding, and that allowed us to do some proof of concept work and developmental studies. And what we saw was that the problems in the drugs area started being addressed incrementally. We made from the start a strict separation between operational and surveillance activities. We said we're only interested in this as a surveillance tool. We're not interested in any of the possible operational uses. And we invested quite a lot in developing ethical guidelines from the beginning. And I think the other thing that was really important from really the start was the emphasis on communication and co-production. In all our presentations, we started that this was a new tool that was complementary to, but did not replace other methods, that we needed not to oversell it, and also persuade some of the people who are very enthusiastic in the field who are doing the work not to oversell the method, recognise that most of the benefits would come from combining the approach with other data sets. And from the beginning, it's really something we wanted to put in context of other information. And that to do that, we really needed to get our drug epidemiologists and our wastewater scientists to work together. And a part of that was also establishing a platform to promote the data, but in a form that had utility for our stakeholders. And if you go on our website, you can see we have a platform that we share with SCORE. It's a co-production effort, but very much on that we come right out and hit you straight away with issues about understanding the limitations of the data, the do's, the don'ts, and also the frequently asked questions, allowing you to actually understand and contextualize the information we're presenting. We also make all our data very easy accessible with interactive tools, so you can look at it, you can interrogate it. And when we tend to promote it as an agency, we don't tend to promote it just in terms of wastewater, we tend to put it into context of other indications, so we use it as part of our analysis, and here you can see an example when we're looking at MDMA trends. And when we really, how do we locate this in our work? We locate it as one of a number of new indicators that all have provide utility in terms of providing more timely data. How do we use it in the drugs field? Well, we really, and basically we have two approaches. We have, so methodologically and literally a pooled urine analysis approach, which is really what we've seen in the last decade or so. Drug consumption patterns become ever more complex and dynamic. And that means our self-report data really is not as reliable as it used to be. People really often don't know what they're using or maybe misinformed about what they're using. So it's useful to have a snapshot of the range of substances being consumed in a location. So we do site sampling of specific locations like nightclubs, city centres, music festivals, for example. And that's been particularly useful for MPS and new psychoactive substances, although it doesn't provide information on prevalence or quantities used. And the other approach we use is more looking at temporal and spatial changes within a population as measured by a sewage system. And what we find there is wastewater analysis can represent a very timely data source. We've heard already from Marta's presentation. But we don't try to provide drug prevalence, just simply offer standardized consumption rates per thousand population. This has proved really useful for looking at trends over time at the population level, in a way I think we struggle to do with some of our other tools. And in some countries now, population coverage is very high. There's a snapshot there from the last exercise in Australia that covered 56% of the population. And the thing that surprised me in last 10 years or so is we've seen that this method is increasingly used in some parts of the global south, in countries where some of the other approaches we've used may be methodologically or practically challenging. So, for instance, you can get some quite interesting data on drug use in China, for example, in this method, and there's really an absence of other sources. We're also seeing work now in Latin America, the Caribbean, South America, and parts of North Africa. Just to give you a little example of how we use it in terms of timely analysis, is just some data looking at how drug consumption patterns changed pre and post-lockdown, and not surprisingly, drugs like cocaine and ecstasy decreased during the lockdown period. And just to wrap all that up, and I think very much my conclusions are going to echo what the conclusions we've already heard. In terms of the strengths, it's not subject to response and non-response biases. We can identify a true spectrum of drugs in a location, in an area, which it couldn't do before. It produces very timely information. It provides information on geographical and temporal trends, and it's relatively inexpensive. In terms of limitations, there's no information on prevalence of use, no information on patterns of use, route of administration, frequency of use, all those sorts of things are quite important to us and we need from other sources. We tend to get city data, but as opposed to national data, and there's all sorts of uncertainties that I don't have time to talk about, and things like back calculation and looking at the issues like the population covered, and ethical issues remain, I think, an ongoing concern. Finally, what were the lessons learned from the adoption process? I think if I look back on it, really important was clearly stated the limitations of the approach and not overselling the method from the beginning. Taking a developmental approach supported by EU research funds was critically important, and so it's possible to incrementally improve the method. Having a strong communication strategy, so we're emphasizing it as a complementary, not a revolutionary approach. Really paying attention at the beginning about ethical and quality assurance guidelines, producing those guidelines and then seeing them enacted through the formation of a community of practice. And then finally presenting the data in ways that it was understandable, had utility to our stakeholders, but they could also understand the strengths and the limitations of the approach. Thank you very much.
Yes, Jackie? Jackie? You? No, you go.
Okay. So we have a few questions also from the audience. One is related to coverage, because not all the Europeans are covered. So especially some countries that may have a high consumption on the east of Europe. So what would you advise, or your impression on how to increase coverage in Europe and maybe make a more specific detection?
Well, I think coverage has improved a lot incrementally over time. I think there's now 123 cities participating in the SCORE network. But we really do have this issue about having city-based data and trying to reconcile that with many of our other data sets which are national. So it's always a little bit of a challenge. But I think it's also an opportunity, because we really begin to see how the local situation within countries can be highly variable. So it's not as heterogeneous as we sometimes assume when we're reliant on national data sets. And then I think the other thing that's actually, I was quite impressed and pleased with, in fact, after COVID, and the fact that this whole approach is now becoming, I think, much more mainstream. I think once you put into place a surveillance system, it's very easy to ratchet it up and add more and more information sources to it. So I think we call quite, in the drugs area, little area, where the investment's always going to be commensurate with other spending costs. So how much are you going to spend on drug monitoring? It's always a finite amount. We're going to really benefit and get leverage from actually mainstreaming of the technique across a whole sort of disease spectrum.
Okay.
Yes, Jackie, perhaps also. Jackie, you've been looking to the questions too. Perhaps you can come up with some.
Just one very specific one to Paul. The others are more general, and perhaps we can take them later. But a question about drug interactions. And it says, could wastewater contaminated unintentionally with various drugs influence the way different prescription drugs are metabolized, adverse reactions, allergic reactions, and so on? Is that something that you take into account, how you deal with that complexity?
Okay, first by recognizing there is an awful lot of complexity there. And for us, actually, one of the issues originally was not simply drug interactions, but drugs being dumped into the environment, either because through police activity people flush a load of drugs away in the toilet, or because of drug production sites. But over time, and I think this is a really impressive thing about the wastewater science, is that the guys and girls go away, and they work on it. And in fact, now we have techniques that allows us, some drugs at least, to distinguish whether it's been consumed by a human being or if it's been put into the environment. So I think the technique is moving on all the time, and by identifying these challenges and people work on them increasingly, we're finding new solutions. And one of the challenges, I think, for people like me who are not a technical expert in the field is simply keeping up with the science, because actually so many improvements have been made over time.
Thank you. The rest of the questions, Henriette and Jacobo, mainly relate to the question of resources and prioritization, and also to capacity. But perhaps I think they're ones that perhaps all three would want to answer, so we come back on that after the last presentation. Back to you.
I think there's another interesting question that may also be interesting, is that normally we just use samplings on already built structures that are not designed in order to give the sample. When we talk about drugs, is there a plan to test specific places, maybe that we think there are consumption, or specific infrastructures where we can suspect that there's, I don't know, different patterns of consumption?
Well, I think this is what I alluded. There's also a sort of operational law enforcement and a more operational use of this technique. And we've been quite careful not to mix up the surveillance with that sort of work because of the ethical issues it raised. So I mentioned the oil rigs. One of the things was looking at health and safety on oil rigs, but we've also had studies looking at prisons, for example, and even some things where they want to look at schools and things. And I get slightly anxious at some of those things where the ethical questions become more pronounced. I presented the stuff in China, and China's really interesting because you don't really get, I don't think, the same sort of survey culture in terms of things like stigmatized behaviors like drug use, so you don't have a lot of other data sources. The Chinese have done quite a lot of work now in terms of using wastewater, but then I heard that they were going to use it as a performance indicator for their police, and then you start again worrying about a different set of ethical questions coming in.
Exactly. Okay. Well, Paul, you've given us some very good overview on limitations and benefits and what you learned. Now, what advice would you give to anyone setting up a community wastewater surveillance for infectious diseases?
Okay, I had to think about this because it's not my area.
No, we know.
But think about things that are transferable. I think first be very clear what the objectives of the exercise are. I mean, this is true for any research study, but particularly in this area. What is being measured and why? It's going to be different in different areas, but you're going to want to usually use the data with other complementary data sets. And you really need to think a little bit about how the population parameters match, because often the sewage system will serve a specific population. I think more than any area, you've got to be really wary of the Dunning-Kruger effect. We're all in this club, and if you think you're not in this club, you're just proving what I've said is correct. We're all unaware of the things we don't know, and I think this is particularly important for this area because the specialisms in terms of the people doing the wastewater analysis and often the disease epidemiologists, certainly the drugs field, are very different. So there's a worry that some important issues can actually get lost in the cracks between the specialisms. So you do need multidisciplinary teams. You need your epidemiologists to be aware of the limitations and some of the basic understanding of what's being tested and why, but you also need your wastewater specialists to understand some of the salient concerns in the substantive area that you're looking at. And so you need to create the dialogue over time. And then I think critically it's important to think about the sources of uncertainty that are not just in the method. And a lot of the time we're looking at what's in the method, to how the measurement, but think about the things that are outside the method that are important to their interpretation. So for us in the drugs world, we really have to look at what's the population being covered. So if there's a large university town and the samples are being taken at a time the students have just come back to term or just gone home for Christmas, that's going to make a difference. We are basing a lot of the work on drug excretion rates, but they come from usually for practical method and methodological reasons, really, quite small samples in individuals, often healthy individuals. It doesn't take into account things like route of administration. So if you smoke, inject or snort cocaine, it's going to have different time effects in terms of your excretion, and we need to think about that. I've talked about dumping of drugs in the environment, that's something we've looked at, but also we have to take into account things like the background purity of drugs being used. So you might have the same number of people using the same substances in the same ways, but if the underlying purity is changing, that's going to affect our interpretation of trends. Finally, I think the points we've all made already, you shouldn't oversell the method, but I think you shouldn't undersell it either, because I've been slightly bemused by people who look at some of the uncertainties in the wastewater analysis and, really worry about them, where they're quite happy using survey data. We know there's serious problems in terms of response and non-response bias, which doesn't seem to bother them at all. So I think it's important not to oversell the method, but not to undersell it. And finally, really keep track of the possible ethical concerns, which I think might change in the future as we get more and more biomarkers. So there may be possibilities of identifying individuals or small populations simply by the improvements in the sophistication of the technique. So I think really always keep those ethical questions in the back of your mind.
Thank you, Paul.
Okay. Thank you very much. Now we have our next speaker, that she will talk about her work as a virologist, especially on what we call the emergency infections. So whatever you're ready.
Yes, thank you. Yes, and I want to build from the leap that we saw during the pandemic in terms of scaling up the use of wastewater surveillance and genomics to possibly the next leap in genomics, and that's working with metagenomic data. Background is obvious. If we look at all the drivers of disease emergence, we can expect to see more of them, maybe an acceleration. And genomic detection is a hallmark of many emerging infectious diseases. Not all, mind you, not all, but many of them. So if somehow our ability to pick up unusual diseases, disease X syndromes, in whatever we do routinely, how good would that be, particularly if that could be done with limited added cost? And that's where I think we need to be exploring. And at the lab level, there are really interesting developments in genomic techniques that may in the future really be employable here. So what I'm talking about is what you're probably all very familiar with, is we have seen the breakthrough of genomics also in the public health arena. To the left, you have your microbes. They have a common language. They have DNA and RNA, and that is what we can read out using sequencing, where the top panel is targeted sequencing, so you know what you're looking for. You design a protocol, and then you characterize that genome, and that, of course, is what we have seen massively during the pandemic, but also has been used in the past for many diseases. This is only a short list. But what I want to point at is the second big development. So here you see the data that is available on pathogen genomes on the three globally connected databases, Database of Japan, NCBI, and ENA database that are synchronized every night. So that's our common open repository for all genomic data. And if you look at where SARS data is, that's that little box on the top right. That is a big box because this is a logarithmic scale. But you can also see there already was a development before that. There was really a steep increase in the collection of genomic data. And now this is done a lot through is attributed to the development and growth of metagenomics. So what is that there? What you do there is just say, okay, I have a sample, whatever, collected wherever, and just characterize everything genomic that's in there. All RNA, DNA, depending on choices made, is characterized, and then you flip it around and dive into that, mine that box of data using bioinformatic tools. And what we've seen from the developments over the past, I would say, maybe 2 decades now, is that what we've been looking for is extremely biased. That's the little red dot. Those are the pathogens that we know, that we can target with PCR assays and maybe a whole genome sequencing. But if you then add in metagenomics in the mix, you see that there's a much broader diversity of viruses out there, the orange area. Some of them may be pathogenic. And that orange area is really vast. If you look in what is sampled in ocean waters, for instance, you can find millions of viral genomes in there. Obviously, the majority of them not harmful to people. But then the question is, if you add this metagenomic tool into your systems, for instance, when looking for a new disease syndrome, added value will very much depend on that specific disease. If you have a disease pyramid, which of course typically is unknown at the start of an emerging disease, that looks like this, with very high proportion of severe or fatal cases, that is probably fairly easy to pick up with regular clinical reporting and epidemiological surveillance. But it becomes much more difficult if that tip of the pyramid is much smaller, like we've seen with COVID, where the vast majority of cases had mild or asymptomatic clinical presentations. That's where you may see big added advantage here. So message here, added value very much depends on the disease that you're looking at. Now here's an example of a study that has been done in the context of a European project, VIO consortium, that's still ongoing, that was derailed during the pandemic because everyone, of course, had to shift work, but is back on track. And here we've looked at metagenomes in 80 large cities across the globe. And what you see to the right is only the viral data. And the more dark the color is, the more viral genomes there are. And you see that these are viruses from a range of different hosts. The bottom row is viruses that infect bacteria, bacteriophages, that we all carry in the millions in our gut, and that really constitute the majority of what you find in wastewater, but is also being used now to normalize, for instance, SARS-CoV-2 testing. You also see viruses of insects, for instance, the second row, and if you look carefully, you see that there is differences in abundances in different geographic regions, where, and that's interesting. So there we may see Aedes albopictus specific viruses. So the viruses themselves may not be so interesting, but it tells you there is those types of mosquitoes in that particular environment. And then the top level is viruses of vertebrates, and you can see you can make a snapshot across the globe by doing this. Now, what exactly you can pull out of this type of analysis depends on how you do the protocols. And there's different approaches. You can have totally what is called agnostic sequencing, where you just do not do any selection, and then you get everything in there. Or you can say, I want to enrich this for viruses that we already know that circulate among vertebrates. Those are capture-based approaches. And here you can see a difference, a comparison of agnostic and capture-based metagenomics in the same samples. And you see, of course, that the capture pulls down much more of the known viruses. Oh, sorry. The question then, if you start thinking to use these methods in, in surveillance, of course you have to understand what is normal. How does a normal urban wastewater metagenome look? So this is what we're studying now, and this is looking in 8 towns across the globe again with longitudinal sampling. So repeated sampling over 2 years of time. And then looking, okay, how much comparability is there? And you see there's a lot of overlap at the center, but there's also some differences in the signal. And that's then, of course, again, interesting, you can explore. And that exploration is done using bioinformatics and using a knowledge about different levels of taxonomy that you have. So the top level here is data on all enterovirus genomes in there, and you see that we find those enteroviruses in all locations quite consistently, but then you move down one level of taxonomy, and that you can do that because you have the genomic sequence. This is sort of typing tool then, and you see that there's quite some differences in the pattern. So samples collected in this global snapshot, you see Coxsackie, I need better glasses, I can tell. I think it's Coxsackie A1, the top orange, in 2 of the towns in South America and North America, but the 2 very different waves of other Coxsackie viruses in those regions. And you see data from a town in the African region where there's great diversity and not so much that wave pattern that we know for enteroviruses also in Europe. And here I want to show a last example, and that's because I really like the exploratory nature of this, and because I think it's a great illustration of what you potentially could do with metagenomics. Not overselling, but I do think it has promise. So this is an analysis of metagenomes generated from samples collected in the Huanan seafood market in Wuhan. That data was eventually released, and then you can look what is in there. So that's been done by teams collaborating across the globe. And you see a lot of different pieces of information here. So in orange, you see were samples testing positive for SARS-CoV-2, where were there SARS-CoV-2 genomes. That's in sort of, you see that is more common in a certain corner. Now, then the question is, what else is there? And then that is by looking at the DNA. Contamination with DNA in metagenomes is there. And you can see that there's not only human DNA, but there's also DNA of many different animal species that tells you there were these animal species present. Doesn't tell you whether they were alive or not, because if you have meat, you can also find DNA, of course. But then the next level was, what else can we find in the virome? Can we find viruses that belong to those, that we know infect those animals? And that also was found here. So 3 different viruses, one very raccoon dog specific, one specific for civet cats, and the right one specific for bamboo rats. So this really adds up to saying there's a lot of positivity of SARS-CoV-2 in a corner with animals that seem to have been alive, because these are fecal viruses, and how else would you have gotten those there? So the takeaway that I want to leave here with is that I do think that the metagenomics is going to move fast forward. We're starting metagenomic testing in a clinical research network now, and used in combination with really strategic sampling, like what was discussed here before, it does have great potential. It's not there, it's very much a research tool at the moment, but I do think exploring its utility for public health is going to be really important.
I'm impressed. Well, 2 questions for the audience. One I think is very interesting is about one of the clear advantages of the water surveillance is the detection of asymptomatic infections. So what's your point of it? I mean, is that something when the infection is very symptomatic, or is better to use it? I mean, maybe a surveillance of flu will add less value than dengue infection, for example, that you have a lot of asymptomatic. What do you think is better to focus?
Well, the exploratory work that we are doing, and this is really research focused, it's not there, I want to be very clear, but we call it a silent epidemic scenario, where you have a disease that may already be brewing, but you just don't know it yet because it hasn't been picked up, because people with an unknown disease can have a range of syndromes that are not very typical and that don't stand out. And you think, for instance, about the delays in detection of first circulation in Ebola, 4 months delay, or in other problems. So that's where we see it, and that's why we say, okay, if you would do this in really high density, highly connected urban areas, that could add to your, early detection surveillance.
Okay. Another question is more technical, but I think it's interesting too, is these samples, for how long can be stored? I mean, how far away can go and make retrospective studies and historical series of maybe different populations of virus?
Yeah, so that's, of course, a key question. So what we are doing is collecting, shipping, freezing. And one question, of course, already is, what do you lose by doing that? We know that there's difference in sensitivity of pathogens to this kind of treatment, rough treatment. We know that for SARS-CoV-2 that really reduces your sensitivity, for instance. So but those are things that really need to be figured out technically. What does the pre-processing do to the quality of your sample and therefore to the outcomes? And so we are doing this as a study, also cost-saving, Valk sequencing. But this is, of course, what you would have to understand if you do it real time, like Marta is doing, adding it into the real-time box, then you have a fresh sample that is different.
Okay. There's another question that is similar that we make to Paul is, do you think there's a potential to sample in a specific place, specifically on the airports where we're talking about emergency diseases?
Well, there is networks exploring that. There's actually also now devices that people can put on the hoses that they suck the airport toilet even, that was developed to make that sampling more easy. So it is happening. I'm not so sure. It will give you a reflection of a few people sitting in a plane, depending on what level of sampling you do. If you do it for bulk airport waste, then that's a bigger reflection, but then you lose the link with where the sampling was from. So I'm not so sure that that's really the best use case, because it's really a relatively small number of individuals. I think this is, if we want to move this forward, we should really think about more aggregated sampling, like in communities, towns. You can think about maybe slaughterhouses, where we are looking now, for instance, with avian flu, you would want to sample pigs. It's extremely difficult to get that done. Maybe we can do, slaughterhouse, wastewater, environmental samples, things like that.
Okay. So the question that of the session is for you. Do you think that the wastewater surveillance is really a magic bullet, or is one piece of the puzzle? What do you ask?
And of course, it's not a magic bullet, but I think it's super fascinating. And I think it's great. So, the pandemic was horrible, but that breakthrough of all of a sudden, oh, it is interesting, we can learn from it. I think that's exciting, and I really think it opens an avenue to explore deeper what else can we do with this. It's not to massively replace things, but personally, if I now want to know how much SARS-CoV-2 there is in our country, I look at the wastewater data. That's the most, unbiased sample that as I see it. So I think we have to get used to it, what you can and cannot do with it, but I do think it's very exciting.
Okay.
Thank you. Well, thank you very much for these three very interesting presentations. I think lots of key points come up and are of interest to us all. We've seen quite some benefits. It's non-intrusive, it's not sensitive to access and willingness to clinical testing. However, we have to keep in mind it's not made to track down communities or populations or individuals. And so these ethical considerations, they have to be taken into account very seriously. And we have, of course, a sensitive issue like drug use, but we can have this in infectious diseases. We've seen it with Mpox, for instance. So this is what a shared experience among all. The challenges are huge also. You've talked, three of you also, of the problems of uncertainties, variability. You need quality assurance, you need protocols, you need standardization, normalization, harmonization, and also, Marta, draw attention to the fact that it may require extensive bioinformatics potential also, and if we see with the perspective you present, that may even increase even more. And that brings us to resources which are required for this, which can be more, although when we look at individual schemes. We can say in some situations it can really be cost effective. There is a whole potential out there, and well, the resources remain, of course, of concern, and we've seen also in the audience that there are questions and people reflect concerns about, is it not going to divert resources from our gold standard surveillance? And we all agree it needs to be complementary, and we have to put it aside with other data, but we still have to be able to produce those data. Lots of things to keep in mind. It's interesting what Paul said, don't oversell. There's so many expectations. Perhaps people will go for it without looking before they start. What will I do with it? What data will I confront it with? What is the real objective behind it? You also mentioned that. I think they are essential issues to be considered too. So if we keep all this in mind, we have still some time for discussion. Are there any questions coming in for the three speakers? Perhaps Jackie has made a small point.
Absolutely, and they all relate to those issues that you just touched on yet, particularly this question of the resources. You referred to that, a concern about, is resource being diverted? Or is this really added value? A question that just came in, Marion, was about the cost of metagenomics and the cost-benefit analysis. Have we done it? Asking a lot about prioritization given limited resources. And this links to the other set of broad questions, which are really related to capacity. And one person saying, how do we ensure representativeness when it's not possible to cover all areas of a country? And for different diseases, you might want to capture differences. This creates a very complex system. How do you deal with that? And quite a lot, and you raised this earlier, Jacobo, but building on that, you raised the question of not all EU countries having the same level of coverage, but he's also people saying not all marginalised communities are necessarily, even in Europe, connected to the wastewater system. So are we missing a whole group of people because of capacity issues, because of infrastructure issues? And one last one, which I really liked, which was about collaboration. And can we see collaboration between the drug surveillance that Paul was talking about and infectious disease surveillance, and maybe this one way to use limited resources most effectively? That's broadly the sort of areas. So it's about prioritization and resource, and it's about capacity.
Yeah, shall I start? Well, I think that's actually, that's why we should explore these kinds of approaches. If you already, our three talks, we can use the same samples, split in three, and then go on with you know, different types of analysis. If you think about, I showed on purpose the example of enteroviruses, where we want to understand patterns and waves in different countries. And this is based on actually a very limited number of samples, giving you a lot of information about big differences in regions in the world that we now do tediously by having patients sampled and individually tested, which in my view is much more costly. So it really depends on how you use it, what you can combine in the analysis, and thinking through and thinking that through, and also calculating, and how does that cost comparison turn out. And I agree, we should be careful about shifting cost to, you know, the new toy in the toolbox. That's always risky. But on the other hand, I would say, how good are we really at early detection of an emerging disease? If you look at what happened in Wuhan, how well would have that have gone in Europe? You know, how fast would we have picked up 50 unexplained pneumonia cases, and then they actually did metagenomics? So I think we have to be also modest there, that we really miss information. So that's where I really see a spot.
Okay. I would like to ask you, three of us, I think Paul will start to talk it. We're thinking about wastewater, but do you think we have to worry about some ethical aspects of what we're saying about maybe sampling maybe DNA of specific persons, of populations. I mean, may we have to worry about some ethical concern about how we use what we found in our wastewater? What is your different point of view, even our contamination, drug use, or virus?
Well, I think from our area that was particularly sensitive because of illicit drug use and the fact that there's a lot of operational law enforcement activities and really not mixing the two things up. I think one of the issues when we started looking at the ethics was it was actually, you had to think a little bit differently than you normally do in terms of research ethics. There was different issues that were coming up. And I guess my concern on that would be really as the technique is developing so quickly and is becoming much more broad spectrum, are there then possibilities that we're missing in terms of ethical risks that simply by the volume of data and the power of modern computer methods to actually identify groups of individuals or subpopulations in ways that could be damaging. I think we have to think about that, but critically to me is being aware of the ethical concerns helps you avoid them. And really I think I think the point of this session is really not overselling wastewater, this is some sort of magical thing that solves all the problems. At the same time, I think we really have to say this is a really valuable additional tool in the toolbox, and we shouldn't undersell it either. So I think there are ethical concerns, but there are ethical concerns with any inquiry we do. We just have to be ahead of the curve in terms of looking at not only what are the ethical issues we're facing now, but what could be the ones that are coming down the line towards us.
Marta, about what happens if I found, I don't know, a contaminant, an arsenic, high levels of a substance that can be dangerous for health? Any legal implications, any ethical implications?
I would step back for a second of picking up human DNA in metagenomics. I think that's a very serious concern, but there are bioinformatic tools already to remove the data from the data set. So when you're talking about setting up a global surveillance system or airport surveillance or aircraft surveillance, then it becomes, of course, a very, very sensitive issue. And when we would wish to share and compare data across region, I think that would be very important to make sure that all human data is removed, and the smaller the community we're sampling, the more important it is. So, but coming back to this question, I think it really just started the thinking going on what you can actually pick up. There are approximately from the same time where illicit substances have been picked up, but wastewater-based epidemiology, also human biomonitoring has started. So exposure to many of the concerned chemicals like personal care products or environmental contaminants, there is probably is a potential to also pick them up in wastewater. But as for illicit drugs, it's also a very sensitive question of where it's actually coming from. So how can we separate environmental pollution and that source of substances getting into wastewater from the actual human shedding or excretion? So I do see a potential there, but we have to be careful about separating these lines of sources of contamination.
I think this is also why you want to really think seriously about how close to individual humans you go with your sampling. If there's been discussions about, sampling in one specific location, reflecting a nursing home or places like that, then, I think you get closer and closer to individuals where you really have to be careful. If you have that, if you tap wastewater from a bigger region in a town, it's much more anonymized by design. And I think that's the kind of thinking we really need. Plus, I really think, so in our project, we have ethicists involved. Because you really need to also, have people pointing out at your own blind spots that I think we all have, to then see, okay, but what if people interpret it this way? Like with any new technology, of course, the discussion on AI, I think, was yesterday. We will need to explore that very carefully.
And it is also a link to the question about marginalized groups, which was also raised by Jackie, and the coverage. So most surveillance systems existing in countries have a really wide coverage based on the connection to sewer systems, up to 90%. But most countries in Europe, I think, have coverage rates about 40 to 90%, which is a representative, but still not a full coverage, of course. But even in those settings which are not connected to a sewer system in Europe, very often the septic tanks are also emptied to the wastewater treatment plant. So those samples are actually feeding into the surveillance systems. But to have a targeted surveillance in a marginalized group, that would often require a targeted sampling. But we come back to the original question: what do we want to see? Why do we want to see it? And setting up a system that answers our public health questions.
But you mentioned the open sewers, for instance, and I was so in that global urban sewage metagenome, there is open sewers in there, and I was actually amazed how much information still could be taken from it. I was very surprised. I was very skeptical of that, but yeah, there's still potential there.
Very interesting discussion. I think we can wrap up this session because time will soon be out. What I've learned from this is that it's definitely an approach we have to study and implement, but we have to keep a lot in mind. Get our objectives clear, make sure data are valid, make sure we have no errors in interpretation, look at uncertainties, keep the ethics in mind and assure that base. If not, you will not even have the acceptability and you cannot even use it for decision making. Well, thank you very much for these enlightening things. Jacobo, you want to have a final word for closure?
I personally learned a lot. Thank you for your presentation. Thank you also to the audience for being here. Well, we're in a moment where we have new tools. Yesterday we talked about artificial intelligence. I think our job is, as scientists, to be open-minded. Of course, there's limitations, there's difficulties, there's things to overcome, but we have to look at them and then select what is really useful. And I think you three give us a very wide and interesting perspective of what the wastewater surveillance can help us. Thank you very much, and thank you very much to the audience also.
Thank you very much, and thank you also to you, Henriette, to you, Jacobo, for a fascinating session. Thank you very much indeed. So time for a 30-minute coffee break, followed by 2 fireside sessions at 11 o'clock. Then later during lunch, just to draw your attention, 2 side sessions, the new initiatives on integrated surveillance under the European Health Union and the SCBTH regulation, and a closed event, but for those of you who are attending, don't forget the EAN General Assembly. And then at 1:45, the Euro Surveillance Seminar and another fireside session in parallel, more poster tours, a side session on risk communication, and then we'll come back for plenary. Just to remind, a little tip that someone gave me yesterday that I give you, where there are parallel sessions. If you want to compare and see which one you want to go to, if you click on one of them and then you swipe left, you can see all the things that are happening at the same time. Very helpful. We'll come back here this afternoon at 4:45 for another plenary on the One Health approach and collaboration at global level, and then we'll have a daily wrap-up. So enjoy your discussions, and I will see you later on. Thank you again, panel. Thank you.
Thank you, Jackie.